Keswani takes another approach. He says, I'm not going to change the immune system, I'm just going to render the nervous system resistant to immune attack. And this is an emerging strategy, and he's going to talk about how he's taken the lead in this area.
Good afternoon, ladies and gentlemen. I'd like to thank Doug, Peter, and Chitra for giving me this opportunity to talk to you today. As Doug had mentioned, I'm going to focus on neuroprotective strategies for neuroimmunological disorders such as multiple sclerosis and transverse myelitis. And I'm sure that many of you in the audience have already seen this slide, but I thought I'd just show it again so that for those of you not familiar with some of these neuroanatomical terms, this would be a refresher. So I'm going to be talking about neurons, both motor and sensory. Axons are the nerve fibers or the wires that connect one neuron to another. And glia are the supporting cells of these neurons. And they include oligodendrocytes, which are the cells that make myelin, which is the insulation around these nerve fibers or axons. As a lot of you are aware in the audience, with respect to multiple sclerosis, there is initially a relapsing remitting course in that there is recovery after an acute neurological deficit. And as time goes on, there is a secondary progressive phase where, unfortunately, neurological deficit is progressive with little relapses and also unresponsive to the presently available immunomodulating therapies, which seem to be good at this phase, but not really in this late phase of the disease. It's thought that the secondary progressive phase is largely due to axonal degeneration. And so this gives the premise or the reason to try to discover agents that prevent axonal degeneration and use them in patients. This slide shows the loss of axons, or these nerve fibers, in a plaque in an MS patient in the spinal cord. So on the left, this is from a normal spinal cord. This is like a cross-section, so it's seen end on, and these black dots are essentially individual axons or nerve fibers. And one can see that the density is much reduced, so there's a fair amount of axonal loss. And there was a lot of work done by Bruce Trapp, who really drew attention to the degree of axonal loss that is seen in diseases like MS. And he showed that in addition to this loss of red or myelin, which covers these green structures, which are the nerve fibers, in addition to that, one also sees so-called axonal transection, or cutting of the nerve fibers due to injury. And it is thought that this process is related to the permanent disability of a patient. So with respect to what causes disability in a patient, the axons, when they are demyelinated, conduct nerve impulses slower. And this may be a reason for the neurological deficit that is seen in a relapse. But recovery can occur by remyelination. So everyone has the capacity to re-insulate nerve fibers. But when there is axonal degeneration happening as well, then there is nothing to remyelinate. One loses that nerve fiber, and it's usually permanent. And so the ideal therapy in a disease such as multiple sclerosis, and this can apply to transverse myelitis, would be something that is anti-inflammatory or immunomodulating. So, for example, in transverse myelitis, intravenous steroids and plasmapheresis may be useful in getting rid of these inflammatory agents that attack the nervous system, but also have a neuroprotective component, so preventing these nerve fibers from degenerating and these neurons from dying. So what possible agents can we use? Well, this just describes some of the classes of agents that we can use. So we can try and make the neurons as healthy as possible with neurotrophins, which are really nerve growth factors. We can give agents that prevent neuronal death, the so-called anti-apoptotic agents. We can use agents to prevent axonal degeneration. This would be very useful in MS and transverse myelitis, where this is where axonal degeneration is thought to correlate with disability. And we can continue to use our anti-inflammatory agents, as they may cause indirect neuroprotection because you're preventing this attack on the nervous system. Also, remyelination strategies, so helping the body re-insulate these nerve fibers would be helpful. For two reasons: the nerve fibers would conduct impulses faster when they've got the insulation, but also there's evidence that demyelinated nerve fibers are more vulnerable to injury by inflammatory mediators. So I'm just going to focus really on how we've approached it in the laboratory. And you've probably heard the term bench to bedside a few times, but this is really how we've done it with one particular agent. So we started off with in vitro research. So this is research essentially in a laboratory using glass cover slips and using our best representation of the nervous system in this in vitro model. And so here you can see, for example, neurons with these nerve fibers, the axons, and these are the glial cells in the background. In this case, this is a culture system in the peripheral nervous system. These glial cells are Schwann cells. And then, essentially, we add agents that we know cause axonal degeneration to these models. This is just an example, and one can see that these axons first develop this segmental beading and then just disintegrate. And so we use these in vitro models of axonal degeneration to screen promising agents. This is just another example. This is a control culture, i.e. a healthy culture. And using another agent, it causes stunting of the axon. So we focused on erythropoietin. We've screened a number of agents, but we're fairly excited about erythropoietin because it has fairly dramatic in vitro and in vivo results. That's using animal models. So why did we choose erythropoietin in the first place? Why did we decide to study it? Well, although it's been traditionally viewed in the context of hematology, that is increasing the number of red blood cells in one's circulation. Indeed, it's used clinically and is presently FDA approved for the correction of anemias associated with cancer and with HIV infection. EPO is actually present in high quantities in the central and peripheral nervous systems, along with its receptor EPO-R. So what is it doing there in the nervous system? Well, the long and short of it is that we think it's an endogenous neuroprotective factor, i.e. it's a factor that we all use to buffer against neuronal and, in particular, axonal injury. So in the brain, it's already known that erythropoietin produced by this glial cell astrocytes is responsible for the phenomenon called ischemic preconditioning. And this is basically means that when the brain is exposed to a period of oxygen deprivation, it seems to actually be protected against a subsequent worsened period of oxygen deprivation, and that's because of this erythropoietin release from the astrocytes. And more recently, some work done in our laboratory shows that the glial cell in the peripheral nervous system, i.e. the Schwann cell, also produces EPO in response to any form of axonal stress, trying to buffer against that axonal degeneration. So this is a natural factor we think works in a neuroprotective capacity. So when these experiments were done, we were thinking, could we use this therapeutically in patients? So if we gave more EPO, then would that increase this neuroprotective capacity? This just shows some of the in vitro evidence. It's just some snapshots, essentially, just to give you an idea. So we did see evidence of prevention of axonal destruction by neurotoxins when we added EPO. This is all in vitro, so I'm still talking about on the glass cover slip. Then we moved to an animal model, and essentially we tried to create as pure a model of axonal degeneration as we could, and the one that's known in the literature is the rodent acrylamide toxicity model. So basically rats are given acrylamide, and this causes axonal degeneration of both sensory and motor fibers. So these rats have limb weakness, and in our model have neuropathic pain as well. And we used outcome measures looking at the degree of innervation of these sensory fibers. This is in the skin on a skin biopsy. One can see that there's no skin fibers in these animals given acrylamide, but when they're also given EPO, one can see that the sensory fibers are still present in the skin. And this actually correlates to a reduction in neuropathic pain. This graph shows what's called a poor withdrawal threshold. So basically, the lower the number, the more degree of neuropathic pain behavior, but we can ameliorate this when we give EPO. This is a motor clinical scale. This is grip strength. So when we give acrylamide, these animals have reduced grip, but we can prevent at least some of this when EPO is co-administered. Now, in addition to this data, there have been several other groups which have shown neuroprotection by EPO, and I'll just give you 3 lines of evidence by 3 different groups, all focusing on spinal cord injury. And so in the first model, this was a crush injury to the spinal cord, and 1 shot of EPO was given within a few hours after the crush injury. In the animals at 4 weeks not given EPO, they were essentially paralyzed and non-ambulatory. This clinical score is called a BBB score. It's a kind of clinical rating score in rats. And the top number, i.e. a completely normal rat, will have a score of 21, and a completely plegic rat, not able to move, has a score of 0. So a score of 10, that's really disabled. But we could, so this group showed that the EPO-treated animals did much, much better. So at 4 weeks had a score of 18, which was essentially normal. So this difference was dramatic. This is non-ambulatory, this is ambulatory. There's another model, spinal cord ischemic injury. This is essentially similar to a stroke, analogous to a brain infarct. This is a spinal cord infarct, and again, EPO prevented neurological disability. And then they also looked at an inflammatory model of spinal cord injury. These are rats who were given or immunized with myelin basic protein and developed EAE, which is an animal model of an MS. These particular rats had bad spinal cord inflammation and disability. Now, interestingly, these rats had very high IL-6 levels, which correlates with Doug's transverse myelitis data. And EPO, in addition to preventing disability, decreased the IL-6 levels in the spinal cord. So this actually suggests that perhaps it may have an anti-inflammatory role, or it could just be interpreted as saying if one has degenerating axons or dying neurons, that incites an inflammatory response, including IL-6. But Doug and I can argue about that later. So based on essentially fairly overwhelming evidence in both in vitro and animal models, we're proposing a pilot clinical trial of EPO in acute transverse myelitis. Now, EPO, because it's already FDA approved, albeit for a different use, i.e. the use in patients with anemia, we can adopt a shortcut approach, because usually it takes a long time, firstly to screen a candidate neuroprotective agent and make sure it's safe, and then get it FDA approved. We're talking about several years. But because it's already FDA approved, it means that we can do this a lot quicker. The proposed trial, which is due to start later this year, involves recruiting 30 patients with acute transverse myelitis. This would be a placebo-controlled trial, so half the patients will get EPO and the other half will get placebo. This is in addition to intravenous solumedrol, so they'll get the conventional immunosuppressant therapies, but in addition get EPO or placebo. And the outcome measures we'll look at will be safety, just to make sure it's safe. We'll give 2 doses altogether of EPO, separated by 2 weeks. The major problem with using EPO clinically is that it increases a patient's hemoglobin. And obviously that's why it's clinically used to correct anemia. Now, data from the drug companies that manufacture EPO suggest that the frequency of EPO administration is critical. So if you decrease the frequency to 2 weeks or less, then you don't seem to result in prolonged survival of those red blood cell precursors. They kind of need a second hit by EPO within that 2-week period. So it's thought that this can ameliorate any increase in hemoglobin. We're also just giving 2 doses, so it's unlikely that will significantly raise hemoglobin. But we are going to be monitoring hemoglobin and checking the blood pressure just to make sure that this is safe in this pilot trial. We're obviously going to be concentrating on seeing if it prevents disability. The reason for using EPO in acute transverse myelitis is that we think there is in this acute inflammatory process, there's a lot of demyelination, which potentially could be recovered because there is this endogenous remyelination capacity. But really what we want to do is try and preserve the axons during this inflammatory period, which we think will be relatively short-lasting because we're going to give anti-inflammatory agents like IV steroids. So that's what we're trying to do, preserve the axons, and so hopefully prevent a permanent disability. We'll use outcome measures that are fairly conventional, like the EDSS and the MS functional composite. And also, we'll be using some of these new exciting imaging parameters that Hugo Moser had earlier talked about, the so-called DTI and MTR imaging, which look at axonal integrity in the spinal cord. So really, that's it. Thank you. Yeah.
What about spinal cord injury?
Well, this would be the perfect paradigm to test EPO. In fact, the evidence is superb that it prevents disability after spinal cord injury. And I'm surprised that no one's done the trial yet. And it needs to be done.
Yep, Alan?
Yeah, this is really for acute transverse myelitis. And so we would be recruiting patients who have had symptom onset within 1 to 2 weeks. So it's relatively short. I think just to start off, we should make sure this drug works in this population. And if it does, then we can think about more chronic forms of the disease. So we're going to start off with really very acute transverse myelitis. Yeah.
How do you determine the dose? Is the dose similar to what is given for an patient with cancer?
Yeah, it is actually fairly similar, but the dose frequency is the difference. So you can give EPO once a week. In fact, anemic patients, rather than doing the 3 times a week regimen, which used to be done, are now going to this once-weekly regimen, which seems to be just as good. And so we're using relatively equivalent doses to what anemic patients use, but we're decreasing the frequency to, this will be 2 shots separated by 2 weeks.
All right, so let's move on. Thank you, Dr. Keswani. So many of you know Chuck Levy. If you didn't hear him playing music last night,